Hello everybody. So chapter 13 covers vital signs monitoring devices. So we're going to talk about how to get those vital signs such as blood pressure, pulse rates, be hooking them up to monitors, getting their blood glucose, getting that full patient report taken care of. Those vital signs are going to give you the signs of what's going on inside the patient's body, those things that you can't see. You don't know what's going on with their heart. You don't know what's going on with their blood pressure. So it's going to help you develop a trend, see what's going on in that patient's condition, if you can see them declining in front of you. And just by going by those vitals, it's also going to help you determine that patient priority. You may go and do your A, B's, and C's and the general impressions and AVPUs and everything like that, and the patient seems okay, but then when you get into the vital signs, you realize, oh my gosh, their blood pressure is really low, or their heart rate's really slow, or the heart rate's really high, things like that. So that assessment of the patient can change as you get more and more information. The vital signs you're going to obtain are pulse, what you're feeling whenever you go up and first touch that patient. You're checking those pulse rates. Respiration rates, how many times are they breathing in a minute? That skin color, temperature, and condition. That is a vital sign. Granted, there's no numerics you can put to that, but that is a vital sign. Pupils, checking how they react to light, obtaining that blood pressure, and our oxygen saturations. The baseline vital signs, that's the first set of vitals you get. This is where everything starts. So your baseline is what the standard is when you first get to them. So every vital obtained after this is going to go into the trend of what the patient's true condition is. You need to repeat those vital signs. Generally, we go for 5 minutes for an unstable patient, 10 minutes for a stable patient. But it takes 3 sets of vital signs to develop that trend. Because that first time you took the blood pressure, you may have been off a little bit, or that second time you may have been off a little bit. So if you can consistently see changes throughout 3 sets of vital signs, that therein determines that there is a trend. When you measure a pulse rate, what is considered normal for an adult is between 60 and 100 beats a minute. So if you can get that pulse rate that's around 1 beat every second, that means that's right about the normal range. But you need to always time these pulse rates. As you gain more experience, you'll be able to get a better average and feel just by touching their pulse for a little while. You'll get a feel for what rate is what just by touching that pulse. So tachycardia, fast heart rates, anything over 100 beats a minute is fast. Tachycardia. Bradycardia, slow heart rate, anything less than 60 beats a minute as an adult is considered slow. Any heart rate above 120 or below 50 is considered a serious finding. Now you need to take into consideration what was going on to maybe cause their heart rates to be at this range. If you have a runner who's in the middle of a marathon and their heart rate's 140, that may be normal. Just because it's above 120 doesn't mean that's a pertinent finding. You just need to realize what actually is truly going on, paint that picture, do those CSI skills. Now, if you find some of those heart rates are like that, be asking the patient, do you know what your heart rate normally is? Some patients have average slow heart rates. For example, Lance Armstrong's resting heart rate is in the 30s and 40s. That's normal for him. If you picked him up, it may freak you out his heart rate's that low, but to him, that's how he functions every single day. So think about this. What's some other situations that might account for that heart rate being outside those normal limits? So as I said, you need to put on that CSI detective hat and be thinking about what instance they were doing. So as we get more detailed later on into doing assessments and asking questions, you're going to learn to know what kind of questions to ask and how to tailor your assessment to knowing what situations they were in to possibly cause their heart rates or the vital signs to be where they are currently at. The pulse quality. So when you measure that pulse rate, you're doing it manually. You need to check for a few factors. The rhythm, is it regular? Does it have a good average beat? You're just thinking about music. Music has that same tempo every time, and a heart rate, a pulse rate should be exactly that same way. It should be consistent. Now there are some folks, the older populations, their heart rates are irregular, but that's normal for them. So be asking if you find some kind of rhythm that's not regular, ask if they do have an irregular heart rate. Checking the force. So that pulse is what you're feeling as those ventricles contract, sending that surge of blood throughout the body. So you're feeling that pulse on an artery. So you should be able to feel a good, strong pulse. But if you're not feeling that, if it feels like that the pulse is really weak and just kind of thin, that there's barely a pulse noticeable, you can deem that a weak or thready pulse. The common place you're checking for a pulse, as I said before, you check that radial pulse for your general medical patient. Use 3 fingers, put across that radial artery, kind of put them staggered, so if it's anatomically, if they're a little bit different, you're still going to be able to feel that pulse. And never use your thumb. If you put your thumb down, a lot of times you can end up feeling your own pulse rate. So just always use 3 fingers over that radial. Now when you do feel that, just for good referencing, if you can feel a radial pulse, that means their systolic blood pressure is at least 80. If you do not feel radial pulse, that means that they are hypotensive. They have a low blood pressure of less than 80. Now there are exclusions that do go in that, but that's just a pretty good rule of thumb. So you see, checking that pulse, on average, when you first begin, check that pulse for 30 seconds, checking rhythm, regularity, and the feel of it, see how strong it is, count for 30 seconds, then multiply by 2. The brachial, most generally that's used for pediatrics. So you would just put a couple fingers directly in between the elbow and the armpit, basically about the base of where the bicep muscle would be, right along that humerus bone. Carotid pulse, that's where you're going to go to first for those patients who seem like they're dead. If you're assessing circulation first, you always check carotid. So if you find that patient that's unresponsive, you think they may be dead, check that carotid pulse first. Or if you're checking radial pulses, you don't feel one there, go up and check that carotid pulse really quick too to make sure that there is one there. I have had medical patients before who don't have radial pulses, brachial pulses, who barely have a carotid pulse, but they're still looking at you. So it's a good rule of thumb on that. If you can feel a carotid pulse, that means a systolic blood pressure of at least 60. And you'll feel that just to the side of the midline of the neck. So the bony stuff you feel in your neck, just a couple fingers width to the side of that, you'll be feeling the carotid pulse. So assessing that pulse, the general good rule of thumb is to watch for 30 seconds and multiply by 2. If you're checking it and it feels pretty regular, it's not a bad idea just to check it, count for 15 seconds, multiply by 4, or for 10 seconds and multiply by 6. I do strongly suggest that when you first begin doing this, to do it for 30 seconds so you're getting a good feel and just a good sense about what's regular and what's not. If you do feel something that's really weak or just feels very irregular, something just doesn't feel right about it, or you feel like it misses a beat or something, you need to check it for a full 60 seconds. So keep that finger on there, talking to him, counting those beats, everything that's going on. As you get more experience, you'll be able to count in the back of your head and still talk. You'll get really good at multitasking. Respirations, rate and quality. Knowing how many breaths are taken in 1 minute. Is it fast? Is it slow? Just something weird about it. So as you describe respirations, they're breathing 20 times a minute, but it's slow or irregular. So that respiratory rate, normal is between 12 and 20 breaths a minute, but that can depend, just as other vital signs can change depending on the patient's condition. Sometimes they can breathe a little bit slower, sometimes they breathe a little bit faster. Your chronic lung people who are smokers or have cancers, they're going to breathe a little bit faster. Your athletes, people in really good shape, may breathe a little bit slower, just as that's just where their training level is at, and that's just how they normally operate day to day. If you're seeing a respiratory rate above 24 breaths a minute or below 8 breaths a minute, those are considered serious findings. When it comes to ventilations, those are times when you may have to intervene, especially that breathing rate less than 8. At a breathing rate less than 8, you ventilate. Rates above 24, sometimes that may just require coaching them, trying to get them to slow their breathing down. Otherwise, if they're not able to maintain their own airway at very high respiratory rates, you have to ventilate them as well. There's 4 categories that go into assessing the quality and rhythm of respirations. There's normal, shallow, labored, and noisy. Normal, hopefully how all of us are breathing right now. Shallow, a person that's not able to take a very deep breath, or the labored, where they're starting to use different muscles, put their body positioning into it, or just really appear to be severely short of breath, can't take a breath in, or noisy. If you're hearing any kind of breath sounds without a stethoscope, that's bad for 1. 2, that's what you deem a noisy breath sound. So checking that rhythm and regularity also. Just as the same tempo you want to check for a pulse rate, you want to do that with the respiratory rate too, to see if it's regular, if they're breathing really fast, then they slow down, things like that. Checking that skin, color, temperature, and condition is going to be a very pertinent finding regarding the patient's perfusion and circulation status. Color, checking around the nail beds, inside the cheeks, lower eyelids. Now granted, everybody in the world does not have the same exact skin tone. There's people different ethnicities, races, everything. Their skin looks a little bit different, but generally around the nail beds, inside of the cheeks, around on the gums, all those areas are the same color. So abnormal skin colors, pale, pretty self-explanatory. Cyanotic means that they are a bluish, grayish color. That's generally caused from hypoxia. They're not getting enough oxygen, or from whether it's a lung issue or a circulation issue, they will turn blue. Flushed, red, I'm sure we've all been there. If you're out in the high heat, you'll get that flushed red appearance. And jaundiced. I'm sure everybody's probably heard of children being jaundiced. When they're born, they look a little bit yellow, just some circulation issues and stuff going on, causing their skin to be yellow. It'll almost look like they've got yellow highlighter going through their veins. Abnormal does not mean normal. Okay, so asking them what is normal. Some people have those flushed red cheeks all the time, or some people chronically will have jaundice or yellowing conditions. Older folks in retirement homes and stuff, sometimes that's just how their skin looks. But generally, in pale, you have an Irish patient with that bright red hair, they're going to have pale and fair skin all the time. Cyanosis is generally not a chronic issue. They do not always appear blue unless it's Papa Smurf. So as you see here, cyanosis, you see the blooming around the lips. No matter what race or ethnicity this child would be, those lips and gums are going to be blue. Pale, that white, pasty looking skin, the flushed red cheeks. They could have a skin tone everywhere. Once again, this could be a chronic issue. Rosacea, different skin. Dermatitis causes red skin. So asking if that's kind of a normal appearance. And jaundice. You see this person here, looks like if they've just got some highlighter smeared all over their face. They'll be yellowed. Checking the temperature. This doesn't always mean that checking for an actual numerical temperature, that you're putting a thermometer in the mouth and everything. Most of the time we're worried about just seeing if it's abnormal, if they're hot, cool, cold, any kind of change out of normal. You just want to remove that glove. You use the back part of your hand. The back part of your hand is one of the most sensitive skin parts of the body, so you'll be able to easily tell if there's anything related going on with temperatures there. Even a lot of times just going and checking that pulse, you'll be able to tell if the patient's warm or not. People who have very high fevers, you'll feel that through their glove. In pediatrics, you need to check that capillary refill. So basically any kid under 6, otherwise as they get a little bit older, not really a good pertinent indicator of perfusion issues. So just push on the nail bed or on the top of the hand. If those wee little kids barely have any nails, just push on the top of the hand. It's kind of that same test you do if you want to see you're sunburned, where you push on the redness to see how long it takes for your skin to return back to its normal color. So you push on that nail bed, you'll see that it'll turn white. See how long it takes for that nail bed to turn back to normal pink. Generally that's less than 2 seconds. If you're starting to see this capillary refill in kids being a lot longer than that, that's very bad indicators. Kids compensate for a long time, so you may be assessing them and everything seems okay, then you check that capillary refill and it's really slow, a big indicator that they are having a bad perfusion status. Checking the pupils. The pupil is that black point in the eye. Everybody's pupil is the same color. So you want to go and shine a light in the eye. As you shine a light in the eye, that pupil constricts. So that's just a natural reflex of the body. It's just kind of like the focus on a camera. That pupil will get really wide if it needs to be getting light in. So in the dark, your pupils are going to be really big, so they need a large orifice open, try and get as much light in as they can. In bright light, it'll get smaller. Now it should. If you see that as you shine a light in their eyes, they don't change or they stay constricted, really small, or pinpoint, as we'll say. So pinpoint being those really small, fine dotted pupils, or if they stay really wide, big indicators that something's not right. So as you're assessing, you're looking for size, equality, and reactivity. So the acronym we use is PEARL, meaning pupils are equal and round and reactive to light. That means they're round, you shine a light in them, they both react equally. So if you shine a light in your left eye and you see that pupil constrict, the pupil in the other eye is going to do the same exact thing, no matter if there's only light being shined in one eye or not. Theoretically, that should happen. If you've seen that that is not happening, very bad indicator. So since we assess pupils are equal and reactive bilaterally, meaning that both pupils are going to react the same, you're going to shine a light into one eye, look in the opposite eye when you shine that light into it, and then just do that in the opposite eye as well, and be covering up those eyes. So if you have a pin light or have them look up at the light of the ambulance, you want to see how those eyes react whenever a light is shined into them. So as you see here, the light shined in the eye, the pupil got smaller, and if you'd see over here, even though there's no light being shined directly into that, that pupil is the same size as that one. That's what you want to check for, that each pupil is the same size as the other. These are deemed constricted pupils, or what we may also say is pinpoint pupils. This is generally caused from people on narcotics. Dilated pupils are generally caused by hypoxia or some hallucinatory drugs can cause those to get wide-eyed. And then unequal pupils, one pinpoint, one regular or dilated, this is generally trauma related or some kind of major head injury issue going on that will cause the eyes to be unequal. But it also can be influence of drugs, or it could be a chronic issue. This could be the normal eye, and a person could be blind in this eye, and that's just how the eye looks all the time. So once again, knowing what is normal for that patient. The blood pressure, that is the force being exerted against the walls of those arteries as that heart squeezes. A normal blood pressure, textbook perfect, is 120/80. Systolic is the top number, diastolic the bottom number. Any kind of change you're seeing in that could be bad. Now, the majority of the world's older population has high blood pressure. So once again, asking what is normal for them. You get a person's blood pressure, it could be 180 over something, and that may be as well as they can get their blood pressure controlled. or some people may stay a little bit lower. Older, especially women, they get up around their 90s, close to 100 years old, their blood pressure may stay just a little bit low. Blood pressures are obtained with a sphygmomanometer. That's a very hard word to pronounce, but from here on out, we're just going to say BP cuff or a blood pressure cuff. So you use that and a stethoscope. You wrap the cuff around the patient's upper arm. That cuff should cover up about 2/3 of the arm, and I said that because they do make those cuffs in different sizes. They make for pediatric ones all the way up to bariatric ones. Those big old people, they get really big blood pressure cuffs. So between the elbow and that upper arm, that cuff, to be appropriately sized, should cover about 2/3 of that arm, with the lower edge of that cuff being about 1 inch from the crease of the elbow. On those blood pressure cuffs, they'll have an arrow saying lining up on the artery here, but the center of that bladder should be right over that brachial artery. As you see here, the cuff, as the artery would come down the brachial side and a little wrap around the arm there, you get this arrow lined up on the arm right there, right where your vessel would be. And it's just generally velcroed on and put in a spot where you can have this gauge visible. Now also, most blood pressure cuffs, these gauges will come released off of there if you just want to take that and unclip it off, lay it on your lap, whatever, if it just works a little bit easier for you to see it that way. As you position that cuff, you want to palpate that artery at the crease of the elbow. Now, a lot of times you can't really feel that pulse really well, especially on some of your bigger population people. But as you get practice anatomically, you'll know where the vessels and everything go through the arm. So as you get the blood pressure cuff on there, position the stethoscope and tap the diaphragm. The little bottom part that goes against the skin, as the stethoscope's in your ear, you need to just put it in your ears, tap the stethoscope at the diaphragm, and then stick it on the arm. As we talk about things in lab, you'll see you need to tap that diaphragm because on both sides of that stethoscope, you can hear out of those. You need to make sure that you're using the right side of the stethoscope. So put the side of the diaphragm you heard out of directly over at brachial pulse, right there at the crease of the elbow. As you see, feeling that brachial artery, feeling where that pulse is, because the diaphragm of that stethoscope needs to go over where that artery is going to be so you can hear the pulse as you pump up the blood pressure cuff. Inflate the cuff. As the diaphragm's over, you're going to be listening the whole time, so you should hear that pulse. So you'll inflate that gauge until it reads 30 higher to where you quit hearing the pulse. So as you're hearing the pulse, keep pumping up until you don't hear it anymore, and then go 30 after that. Then slowly start deflating the cuff. Once you start to hear that pulse again, that's your systolic pressure. To get the diastolic pressure, you'll keep deflating the cuff. So as you've deflated it, you first heard the pulse, you got your systolic pressure, and keep deflating it until you don't hear a pulse any longer, and that's your diastolic pressure. Now to do it as by palpation, you can do this without using a stethoscope. So you'll put your fingers on, feeling for a radial pulse, and then inflate the cuff. Inflate the cuff until you don't feel that pulse anymore, and then deflate the cuff. Deflate that cuff until you feel the pulse again. Once you do feel it, same thing as whenever you use your stethoscope, that's your systolic pressure. But since you can't deflate until you don't hear it anymore, we just write that as over palpation or over P. So it'd be, for example, written as 120 over palp. Pediatrics are very hard to get blood pressures on. They're squirmy, they're really little, it's hard to hear because mostly all we have is adult stethoscopes. We don't have those little precise pediatric ones. And honestly, most of the time, a kid under the age of 3, it's not a very reliable indicator. Your best thing is going to be checking their appearance, just that general impression, do they look sick or not, if they're in any kind of respiratory distress, if they're unconscious, and checking that capillary refill. And overall, just checking to see if they have good pulses and skin circulation. Measuring the temperature, knowing what activities and everything go into that. their age, anything else that's going on, and where that temperature was obtained at. Now, there are the different head scanners, the laser pointer ones, but the most accurate way is a rectal temperature. Now, that's not something we routinely do on the ambulance, so don't get freaked out. You don't have to know how to take a rectal temperature, but most of the time we do it in the armpit or in the mouth, and most generally we're worried about taking a temperature on pediatrics because fevers in little kids is what we worry about more so than a fever in an adult. As you see, taking the temperature in the mouth, one of the other best ways after rectally. So generally in order, it's rectally, in the mouth, in the armpits, on the head, or using the infrared scanners. Oxygen saturation, we'll use a pulse oximetry, that little red light that shines through your nail beds to obtain and see how much oxygen is attached to that hemoglobin. See in the picture, it's also going to give you a pulse rate. So the little indicator of the heart, the pulse rate is 82 with a saturation of 98%. And you also want to know what that is, whether that's on room air or if you've given them oxygen and that's what you've gotten into. But always document these numbers every time you obtain them. So obtaining those pulse ox numbers, normal above 94%. We want to aim for that 94 to 99%. Anything less than that is considered hypoxia, whether it's mild, still in the 90s, significant in the 80s, or that severe hypoxia, less than 85%. A lot of times if you're going to be assessing a oxygen saturation and it's showing less than 80 and that's not always 100% accurate because generally at those points there's being perfusion issues and stuff, and don't always just rely on that equipment. If you put the pulse ox on and it shows that they're 80% and are not in any kind of respiratory distress, they're just complaining of abdominal pain, you may just want to check the equipment to make sure they don't have fingernail polish on or anything like that. We can rely on the equipment, but they're always not 100% reliable. You still have to assess your patient and do it manually. So the accuracy of those pulse oxes can be affected by multiple things. So hyperperfusion, if there's no blood getting to that nail bed, that red light's not going to be able to hit any red blood cells, any hemoglobin to see really what's going on. If there's carbon monoxide, those CO molecules have about a 300 to 400 times greater affinity to bind to that hemoglobin than the oxygen does. So it may still say 98% and they're in respiratory distress because that's actually a measurement of the carbon monoxide on the hemoglobin, not oxygen. Other excessive things, buildup of CO2 in the body can skew it. Different types of poisonings, the nail polish or anemia, anything that affects circulation or binding of those hemoglobins. Using a blood glucose meter, this is what we use to check the blood sugar levels, especially in diabetics. It just measures the quantity of glucose in the bloodstream, glucose being that a big staple of the energy we need. But the body only needs that certain happy balance of it. Too much is bad and not enough is bad. Typical pre-packaged setup of how you'll find a glucometer on ambulance. The glucometer, the test strips, an alcohol prep to sanitize your finger, and a lancet. Use these as you poke through the skin to get that drop of blood that goes on the strip. The strip's in a glucometer. And it'll give you the reading on the screen of what your blood sugar level is. Now, not all places will allow EMTs to do blood glucose readings, so all that's going to be dependent on local protocols and whatnot. The glucometers should be calibrated every once in a while. There are kits that come with every glucometer. They'll let you check and make sure that they're still calibrated properly. I have personally seen glucometers be bad that'll give a patient a reading that says normal, but then if you check it with another one, it says that it's low, and sometimes they just need calibrated or cleaned. or just ultimately replaced. Steps in using the glucometer. Prepare the device, get the test strip lancet, open up your little package, get everything out. Take out prep, clean the patient's finger with alcohol because you don't want to be poking dirt and debris down into the patient's skin. You want a nice clean surface. So once you get it wiped off, and it's a good rule of thumb once you put the alcohol in there to let it dry. Just air dry just a couple seconds and it'll get dry. So if the alcohol's still in the finger and you poke them with a needle, it's going to sting just a little bit. Once the blood starts coming out, apply that blood to the strip. At this point, that test strip should already be in the glucometer. It's on, and the screen will generally have a flashing picture of a blood drop telling you it's ready to start reading. So you've poked a hole in the finger, you got a little drop of blood, and you just hold that test strip up and it'll pull the blood up into the test strip and start analyzing. So at that point, once it started analyzing, just put a band-aid on the patient's finger. So your normal levels, usually 60 to 80, depending on when they've eaten. Anything less than 60 is a bad finding, but anywhere really from 80 to 120, 140, it's kind of one of those things that depending on the person, when they've eaten, everything, there's a wide range that goes into this. But if it's a person who hasn't eaten in 12 hours and their blood sugar is still 200, that's a bad sign. Or if it's a person who's having issues and they did recently eat and their blood sugar is still only 60s, it's a bad sign also. Usually that means if their blood sugar is low and they're still eating, they may have taken too much insulin, or if it's high, they may have not taken enough insulin. With pediatrics, knowing their age and what a normal set of vital signs for those kids is very important. And also knowing that that little kid is not going to have that heart rate of 60 to 100 and a good blood pressure of 120 over 80. Little kids, they breathe faster, their hearts beat faster, and their blood pressure is lower than what an adult is. So taking all that in consideration will help you know whether everything with that child is normal or not.